say, give me one fun fact about yourself. Okay, whatever. So hey guys, Anupam Goel, general internist by training, and I've been with United for about a year. I want to try to pivot this a little bit. You've heard some great stuff about payers from Eric, some really good stuff about moving to behavior change from Josh, and so this is really a riff on those two ideas. I did not see their slides. I didn't even know their names before I got here, so that's how it is. Okay, so everyone's seen something like this that says healthcare costs have been rising year after year after year. That's the curve. I think somebody said that last year the premiums for an average family was $20,000 a year. Absolutely nuts. Here's a more nuanced prescription. So if you think about as a percentage of GDP, we are really spending more and more and more. And we thought we'd hit 18% by now, but we haven't. I don't know if that's good or not. What's more interesting is if you compare us to other countries, we are killing it, right? We are definitely better than average. That's all great to spend more money, and I'm all about spending more money. That's why we're here. But if we're not getting more value, it's probably a bad deal. So let's talk about this. This is the idea of age-standardized disability-adjusted life year. It's a fancy way to say, let's combine mortality and morbidity in one metric. And so what you're seeing is we are seeing a drop with a slight leveling over the last 30 years or so. I'm sorry, 27. If you look at high-income countries across the world, we are not killing it. We are getting crushed. So we're spending more money than everybody else, and we're getting worse health outcomes. What the hell is wrong with us? We're the best of the best of the best. Here's another way to think about what we're doing. If you carve in a little deeper and say, where are we losing these disability life years? Where are they going? Here's a United States at the top, and then a bunch of countries at the bottom, and they're all high-income countries. How you don't want to define that. The orange is really higher than average for the country, and then the blues are lower than average. And so what you'll see is we got a bunch of orange. We're doing great, higher than average. What's interesting here is that the top two reasons for above average loss of disability, loss of quality adjusted life years is really drug use and ischemic heart disease. And so we've heard a lot about heart disease and diabetes. And I just want to do a quick call out to drug use. And I think you've all seen some version of this in the literature in the last decade, that people are killing themselves with drug use. No matter what drug you pick, we're doing it, and we're doing it well. So this is not about technology or about IT or about telemedicine. This is an idea. This is a woman, a PhD professor, who was addicted herself and wrote a book called Never Enough. And she talked about there is no drug that's going to save us from drug addiction. It's going to be connections with people. That's the key. And I thought that was really moving to me to say, we're not going to over-engineer the solution here. We're going to have to think about how to connect with people again to address loneliness, depression, drug abuse. Okay, so let's go back to heart disease, because that's easy. We can all get excited about heart disease. This is a paper about 2 months ago. Yusuf is a phenomenal researcher who's done great work in meta-analysis across the world. And he tried to say, what can I tease out in terms of reversible causes of heart disease? And he came out with these things. And so these are modified risk factors. There's a big chunk in purple and a big chunk in pink. The pink is metabolic, and there's a list there. The purple is really these behavioral risk factors. So if I then look at it for overall mortality, since heart disease is such a big driver of mortality, it seems to make a big effect on overall mortality. Now you'll see a bigger impression on tobacco and alcohol and diet versus the other traditional heart disease ones. So if you think about overall mortality, thinking about behavior makes a difference. Think about heart disease specifically accordingly. This is a very complex slide, and it's worth your time to pull the articles from a guy named Vinod in Medical Care earlier this year. And he tried to say, where is the role of information and communication technologies in the milieu of upstream and downstream factors? If you look to your left, my right, he's talking about upstream factors, and there's roles for information technology there. And as you go over this way, you'll see more downstream factors, kind of closer to the person. And I think we in America have to think about downstream and upstream. We are horrible about upstream. We do really good work to saying, it's your fault, figure it out. So to that end, I've just highlighted a couple points that I think are interesting from a technology perspective, right? How can we help people cope? Can we do better jobs with health screenings? You've heard a lot about that. Can we shift attitudes and behaviors to help improve healthcare? Those are things that I think we can do. And then can we focus on these behaviors that make a difference, like smoking and diet, physical activity? Okay, so Vinod went on and he said, there's a bunch of things we can do, but I think in healthcare here are the top 10 things that make a difference. And of those 10 things, this is no longer Vinod, this is me, I think we've done a great job on these. We've done a great job showing data. We can show data like nobody's business. We can educate. We can do lots of PDFs and videos and singing cartoons. That's great. And then we can say patterns of disease. So all that is interesting, but not sufficient. So here's another paper out of a woman named Ida Sim, published a paper earlier in September in the New England Journal, and she talked about mobile technologies in health, and she had a beautiful 6,000 words about what she thought. And just for you guys, what I'm going to point out is The primary focus is these devices, either they're on the person or they're getting uploaded to some central platform. They go to this cloud place, and then they either go to the provider or they go to the patient. And ideally, in a self-quantified person, they use these numbers and change their life. There's the technology. This is what I use. It's not connected to anything. It's a spring-driven scale, and it doesn't even work. I'll tell you, it's not accurate. But what it tells me is it tells me what my weight was today versus yesterday. And that's all I need. I don't need it to know 2 years ago. I just want it yesterday. Nobody can hack it. Nobody can go back and figure out how much I weighed 10 years ago. But it helps me change my behavior. It makes me a more conscious person every day I get on the scale. Had a bad day, it'll show up the next morning. If I had a good day, the weight goes down. So is this more powerful than that? And I think my interpretation of literature so far is we have not shown that an increasing technology, increasing information, has changed increasing behavior. So there was a couple of comments about trust and some words about engaging with members. And I just want to talk a little bit about this. I think telemedicine has been seen as as a system we can use for urgent, short-limited diseases. And there's some conversations that are worth having that could be happening over telemedicine, but we haven't done a good job of. And so here's an example. This was Institute of Medicine about 5 years ago. They talk about this diagnostic cascade and what it looks like. I look at my buddies in the back who do diagnostic work. And there's a conversation about diagnosis, a conversation about treatment, and then outcomes. And all those things require nuances in conversation. If diagnosis isn't enough, you can think about what does that mean in terms of their own goals. Do we do a good job eliciting healthcare goals from members about what they want to do? No, we really don't. Doctors don't have time for it. Members aren't sure what they want. Values and preferences change over time. Those are things that we could probably do over remote communication week after week rather than expecting to happen in 15 minutes. And then this last piece, since I'm a guy with a prostate, this is interesting to me. Prostate cancer is a challenge, and it's a complex answer. It's not a get screened and get your prostate taken out. Sometimes it's radiation, sometimes it's radiotherapy, sometimes it's other things. And so this is just an example of the nuances that might be involved that can be done remotely or face-to-face, but requires some understanding what the member cares about and what you can provide. Okay, so I'm not a marketer, but I know many of you here are, and I just say from my perspective, I think you've got to do some stuff to engage members. So that's great. We'll do this work, and there's some work here that I pulled off the web that says it's about attention and transactions and productivity. And so we in healthcare said, we're going to do it, we're going to build it. People are going to love telemedicine, and no one's showed up. I mean, telemedicine has been single digits, right, for a while. We keep waiting for it to show up, and no one's coming. So where is it working? So here's some interesting stuff about utilization for healthcare services, and what you'll see at the top, this line in the middle is the 50th percentile. So most folks aren't, less than half folks are using these important things. We think chronic conditions can be monitored. No one's doing it now. So what is working? Erectile dysfunction, hair loss. So these things members really care about, patients really care about, and they're going to pay good money to get it. And so these are some examples of that work. And so I'm going to make a hypothesis. There's no literature here. I've got no evidence. This is Anupam's own idea. And that is, we are willing to pay more money and work virtually when we have a confidence or commitment in the treatment plan. If you can help me understand that I've got Hep C and I need treatment, I don't need you to do it again to me face-to-face. I can do it remotely. If I'm trying to have a baby and I know I need help, I will go anywhere in the freaking world to get it done. And I can do it remotely, I can do it face-to-face. But you've got to have confidence in the plan or the diagnostic approach. Otherwise, it's not going to work. And to me, for my money, I want to make sure that we get the diagnosis right. And again, that doesn't have to be face-to-face, but we haven't done enough to that engagement to get people to come back. All right, so here's where we start with, playing to our strengths. What can we do? Interact with experts to increase trust, and then interact with other members of the team. So I'm saying doctors are really expensive. We cost a lot of money. So you want to use those in the beginning to make those complex conversations, if they are complex. Maybe they're high trust instead. I trust a doctor to make this decision. But after that face-to-face evaluation, can we make a handoff to other members of the team? And I think telemedicine is focused a lot on doctors and other health professionals, but I think there's other opportunities, really around chatbots, around health coaches that might be just as effective. Back to my scale. So this is the thing that keeps me motivated, and this is the monster under my bed, right? So we have this fight that goes back and forth. I try to do this, but I try to do this. So what's the behavior shift I want to do? This is an article from about 10 years ago that talks about behavior. And historically, we focused really on knowledge. If we just make people smarter, they're going to do what they want to do. So this is a model that's been paid for over 40 years. This idea of the transfer theoretical model, really refined in smoking cessation. We talked about these stages of change. It doesn't work. So I have to say, I'm actually interested in this new model. This talks about self-determination theory. It talks about this idea of identity. What do I feel and value and care about? And if I care about it, it's not impinged on me. I have some autonomy to make that decision to make a better behavior change. Shifting people to being told what to do, telling my son to play the violin, versus him saying, Dad, I'm going to go play, makes a big difference. And the quality of what happens makes a difference. So this idea that goals are shaped by identity. Identity then can help be informed by behaviors. If I do this, I must be that. Here's another way to think about this. This is a way to link extrinsic motivation like gamification with things like intrinsic motivation. So we're doing all these work, and so if I win things, if I get pride from someone telling me I won a race, I may develop intrinsic motivation to run more often. I think it's worth pursuing. One thing just to watch out for, the more you make people exercise or you provide them with this intrinsic motivation, you don't want to make them neurotic. So that's what that was about. And so I think thinking about this more holistically, that includes other ways to shift people to think about behavior shifts, will be more effective in changing healthcare in the long term. This work was done by McKinsey about 9 years ago. So they were thinking about this longer perspective and would love to see people think about this in their own models of thinking about telemedicine and how it fits individuals and networks and so forth. So we start here. I think there's opportunities for many companies, yourselves included, to think about this larger space, to think better about healthcare. Here's a summary. We don't care about that. Okay, let's go. Questions? It wasn't that good. Come on.
Questions? We have.
So gamification seems to be one of the buzzwords
It gets
these days.
crazy press. Everybody loves gamification.
So gamification is competition, right? It's
Indeed.
I'm better than the other guy because I can do this and I'm better. So how does that fit into your motivation?
Yep, let me get back here. So gamification by definition is extrinsic motivation. There's some competition and I'm going to, ooh, that didn't even work. There's some competition that's happening and I'm trying to achieve this win. And so what we find is if we do gamification, people get excited about the race and then they stop. And so this idea that gamification can somehow lead to intrinsic behavior change is still open. There was a paper published in JAMA last month that worked on mostly upper income consultants across the country that try to do gamification versus support versus usual care to increase step counts. The step counts in the gamification group went up about 25 steps. So interesting, and then it dropped off in 3 weeks. So what I'm arguing is gamification is interesting for extrinsic motivation. I want to win that prize, but once I got the prize, do I keep going? And that's been the challenge of gamification. So I think it's gotten a lot of press, as it should, because every IT person says gamification is the answer. I play video games, therefore it changes behavior. Maybe not. Maybe not. So I hope gamification works. It hasn't worked to my satisfaction in any literature I've seen to date. If other people have heard something, that'd be great, but I'm really struggling with how to incorporate the behavior change in that way. I'll tell you my own journey. I pick on the scale because I was pre-diabetic. And so that was a strong motivator. I had family members who died of diabetes, and so that was the intrinsic motivation. I want to be alive for my kids. So what does that mean? It means a different choice. So if I want to be alive for my kids, that means I don't eat dessert every day. If I don't eat dessert every day, I weigh myself. So that was, I'm not depriving myself. My identity is I want to be a better father. So I think that's really the thing we haven't talked a lot about, is identity is really the driver, not someone pushing you or paying you or making you think differently about yourself. That's why diets fail.
Could I ask you about your scale? So what would it take for you to move to a digital scale? Is it like the fear of privacy?
I don't trust you, Milton. You're going to hack me, baby. I don't want you to hack me.
So,
But I think the real question, Milton, is what's the marginal value of a digital scale over an analog one?
okay.
And no one's explained that to me. Like, I'm still struggling with what's the marginal value? What does uploading my measurement do for anybody?
So we have, so when our partner is Body Trace, right? So they have the digital scale with a SIM card built in, right? It's just no setup, no instruction, you step on it.
You haven't answered my question, Milton. Why?
But I think
Why should I do it?
in that case, is now you have the provider, sending you
I
back,
don't want the provider to
motivating
tell me
you.
what to do. I'm good. So if I'm gamifying, then I do on my scale, right? So if I'm on it in a competition to lose the most weight, if I'm the biggest loser, yeah, sign me up. Well, what's my business, man? Like, that's my business. That's not your business.
Got it.
Milton, if you give me a reason to do it, I'll do it. But I'm still telling you, like, when Google has all this stuff and we're all worried about privacy in Europe and America, it's really tough to say healthcare data will not be used against you, because it will. I work for United, for God's sake. I'm looking at Eric. Dude, like, We can say what we want, but no one's going to believe us because we set premiums. Our whole life is based on premiums. So controlling healthcare data in some ways is almost as important as controlling financial data. Equifax gets breached, whatever. One of us gets breached, we go bankrupt.
Okay, I'm going to give you a reason.
Please!
The truth of it is a spring scale you can screw with. Lean to the right, lean to the left.
Oh, absolutely. You can totally game that thing, right?
Right? And a digital scale, once it's set, you have to get off of it and reset it. So you know you're cheating. And it always comes up the same.
Okay. So I can have a digital scale that's not hooked to the internet, right?
Oh, yeah.
Fine. Okay. Great. So guys, this is just a caution to all of you working in telemedicine, is you've got to make the argument, why should I get connected? And I just think we lose that over and over again. I've got some ideas about calibration. Okay, that's fine. I think the bigger question is, why engage? And so I think when I look at the telemedicine numbers, all of us, I'm looking at my friends over at other payer space, we all keep waiting for telemedicine to break the monopolies of large health systems, and we have not been able to do that because people don't see the value, and they trust face-to-face more than telemedicine. So make that case stronger.
Got it. How about, in the interest of time, but definitely, so we're going to move on to the next speaker. Thank you so much for that exciting talk.